let's see. Am I sharing my screen?
Yes, we can see it.
Yes.
Just can't figure out how to go back to the first page. Oh, okay. All right, everyone. Today we're going to be talking about Allen cognitive frame of reference. So we have Claudia K. Kelly. She started the cognitive disability model in 1960s, along with her colleagues at Eastern Pennsylvania Psychiatric Institute. And after observed cognitive impairments in individuals with chronic mental illness, that is when they developed Allen Cognitive Level Screens in 1985. During the 1980s, the model gained traction in mental health settings. Over the time, it was refined and applied more broadly, including in dementia care. Oops.
The key principles for the Allen Cognitive Level Screen and the Allen Scale is that they were assessed through complex leather lacing stitches. So you would run the stitch, whip stitch, or a coordinative stitch. It became more progressively harder the more loops and knots you would go through. It also assesses cognitive functioning and disabilities by observation of sensory motor actions. Results will determine the Allen scale in 6 levels of cognitive abilities. Now, the first 3 levels of the Allen scale is red level 1, which has to do with awareness, automatic actions. The individual's attention span is fleeting and very brief. They require 24-hour total assistance to produce automatic actions such as swallowing, locating stimuli, rolling in bed, and raising body parts. They are also bedbound patients. They grab by reflex and hold onto it, usually incontinent and may resist care, usually cannot tell you what they want and cannot answer to certain stimuli. Next is orange level 2, which has to do with gross body movement, postural actions. Their attention span is approximately 3 minutes. Like level 1, they require 24-hour care and maximum assistance for transfers. You would want to create a calm, sensory-rich environment, whether it be no noise, no loud, TV has to be off, windows closed, doors closed to the main hallway of whatever facility they may be at. And familiar functions they can participate in is moving to their favorite music that they've listened to in the past as well. It is very tough to transfer these patients as well. They may be wheelchair bound, and they also may have balance deficits because of their immobility. They are also fearful during movement, which can cause more setbacks as well. The next level would be yellow level 3, which has to do with spontaneous manual actions, repetitive and familiar actions as well. The maximum attention span is usually 30 minutes. They rely on tactile cues and demonstrations, ability to use their hands, arms, and legs. They usually require moderate assistance. They're able to follow movements and able to ambulate and wander.
And then for level 4 blue, it is about goal-directed activities and sequence in using familiar tasks. They also acknowledge visible errors and seek help if they notice that they have mistakes. They also follow simple instructions, however, it requires minimal to contact assistance, and they're able to sustain their attention for about 1 hour. And for level 5, it is mild impairment with standby assistance for new tasks. But due to their safety, judgment, and impulsive behavior, they will require corrections. However, they're able to learn new things and memory aids necessary for better outcomes. And for level 6 is they don't really have that much cognitive impairments or not at all, and they will require no supervisions. And for the theoretical foundations of Allen cognitive frame of reference. Piaget's theory of intellectual development. It is originally based on the ACL is based on his theory, and which is help assess, assist, and adapt the patient's environment based on their cognitive disabilities and abilities. And it is also a neuroscience information processing, which incorporates principles of neuroscience theories for understand and how cognitive function and influence task performance.
And speaking regarding frame of references, how that informs occupational therapy practice, evaluations of cognitive levels, very important, so that the occupational therapist can provide the correct goal setting and intervention planning. Another important piece of the ACL is to understand the person's cognitive level, their capabilities and limitations to provide realistic and achievable goals. They also have to keep in mind environmental modifications, client-centered approach, interdisciplinary collaboration, and collaboration among health professionals.
All right, so we're talking about implementing the Allen cognitive levels in real life situations and scenarios that how therapists might use in the real world. So obviously we got to understand what level 1 was. Thank you, Darwin. So most of the patients there or clientele are bedbound patients. So more so the sensory aspect of it. So some techniques that will be done with sensory stimulation techniques and interventions. We want to provide food for the resident because they can't feed themselves. Provide gentle range of motion techniques so that they don't develop any contractures or muscle wasting. But we also want to know, like, watch out for facial expressions because when you're doing the range of motion, you can experience some grimacing, which can indicate pain. Then there's orange level 2, and understanding that capabilities. Most of those patients, clients, they are able to walk, able to stand with obviously a moderate to maximal assistance. Encouraging self-feeding, some interventions, bright colors to grab attention. Most will follow one-step directional cues, and you would want to make sure the environment is safe for out of distraction for them to stay on task. Then there's yellow level 3. Their clients here can perform tasks more better. They understand what's going on, but if they fall off the bank, don't try to reorient them to reality, but rather understand what they're going through and encourage them that way. And then encourage their use of their capabilities, what they have left. Then we got level 4, more validating feelings, same with level 3. These clients can complete their task, but they require a little bit more time than usual. They can learn new tasks, but they must repeat the skill over and over again to retain information. And usually in these levels, they require minimal to contact guard assistance. Level 5 is just slight impairments to their cognition. More so, safety awareness interventions will help those clients, and then any trial and error problem solving will help. Level 6, there's no cognitive impairment, so just any motor learning interventions will help with the patients. You can give them multi-step directional cues and interventions, and then they will fully understand.
Okay, and I'm be speaking regarding advantages of using the ACL. The ACL is a structured framework, allows for much simpler targeted interventions by the therapist, also improve client comprehension. Therapists can better grasp the necessity of their clients when levels of cognitions are sorted into categories, and this translates into more individualized kind of care. Center on the functional results. ensures that interventions are direct and relevant to the clients, also facilitates progress monitoring, enables therapists to note changes in cognitive functioning over time, which helps to determine the effectiveness of interventions and make the necessary alterations to treatment. It also encourages self-sufficiency. When we mold our methods to the specific way a person thinks, we can coax them to do more and more for themselves. Some limitations of the ACL: cognitive functioning oversimplification, oversimplified the many facets of cognitive functioning. Also, cultural and contextual factors might not completely consider cognitive and contextual elements that affect thinking and occupational performance. Insufficient research proof. More empirical research is required to prove its effectiveness and applications in various settings with different populations. Reliance on the therapist's insight. Measurement of cognitive levels depend a great deal on the therapist's insight and clinical judgment. And lastly, demanding of resources. The need for extra resources, training, and time that some practitioners in healthcare settings may not be able to spare. Thank you.
Thank you.